Hello, everyone. This is Kate Myers, Senior Program Officer at the California Healthcare Foundation, and I am very pleased to welcome all of you to our webinar today, focused on expanding palliative care in rural settings, challenges and strategies. Before we dive in, I wanted to just briefly introduce the folks who you'll be hearing from in various capacities on today's call. First, our primary presenter today is Kathleen Kerr, who is a healthcare consultant whose work focuses on developing sustainable models for community-based palliative care. We'll also be hearing from our other two co-faculty members, in addition to Kathleen, from the Rural Palliative Care Initiative that we'll be talking about more today. And those include Monique Parrish, who's Director of Life Course Strategies, a consulting firm that provides project management, research, and analysis around health, social service, and palliative care needs of underserved and underrepresented communities. And Lynn Soronsky, who's a palliative care nurse administrator and consultant who works with new and developing palliative care hospital and outpatient models. And again, Kathleen, Monique, and Lynn were our co-faculty for our Rural Palliative Care Initiative that we'll be talking more about today, and co-authors on the report that was just released a few weeks ago describing that work. Next slide, please. So just a couple of logistics before we dive into some of the content. Just to let you all know, we are recording this webinar, and both the recording and slides will be posted to the California Healthcare Foundation website. The address is listed there under events. And we would love for folks to liberally use the chat function in Zoom today. We found this has worked well in other meetings where we can use chat not just for questions, though certainly that's a great place to put questions, but also as Kathleen and Lynn and Monique are sharing the content today, if folks can share their own observations or reactions or thoughts, information about how some of these issues pertain or don't pertain to your organization, including responses to other people's comments or questions, that's a really helpful way for us to hear from you in a way that sometimes we can't in a just Q&A fashion. We will also try to address as many of the questions as we can, either live during chat in response to your question or at certain breakpoints during the presentation. And one thing that makes it a little bit easier for that chat function to work well is if you open that box up in Zoom. So if you hover on the bottom of the page, click on the chat bubble, and then you'll see a box come up. If you're going to send a message, make sure it's going to all panelists and attendees so that we all see it and we can all keep track of what those comments are. Next slide. All right, so before we dive in, I just wanted to give a little bit of background to the work that we'll be describing today. As many of you on the call know, the California Healthcare Foundation has had a long interest in expanding access to and quality of specialty palliative care across the state. And in more recent years, that's included a deep focus on community-based palliative care, especially for low-income and underserved populations. And the specific interest from CHCF in palliative care in rural areas was in part sparked by some work that Kathleen Kerr conducted for CHCF back in 2014. That was CHCF's first attempt to kind of map the capacity and the need for palliative care across the state. And in that effort, we identified no community-based palliative care services in 22 counties at that time, back in 2014. And most of those counties were rural. At the same time, many of you will remember that also in 2014, California passed Senate Bill 1004, which would require that eligible Medi-Cal enrollees across the state to have access to palliative care services. But of course, a requirement like that doesn't do a whole lot of good if services simply aren't available in a given geography. So we were really interested, given that a lot of California is rural, many rural areas have high proportions of Medi-Cal enrollees. We were really interested in CHCF to see how we could support the growth of palliative care services in rural areas, and recognizing that rural areas face different types of challenges, how to best support that growth. So a few efforts leading up to the most recent work. In 2016, we published an environmental scan on rural palliative care that was led by Monique Parrish on this call, that address some of the challenges and opportunities around rural palliative care, as well as describing some models from other states, including a program from Minnesota that was led by Lynn Soronsky, also on today's call and part of our faculty. And then late in 2016 and into 2017, building on the model we had used for payer-provider partnerships more generally across the state, we launched a planning process for health plans and palliative care provider organizations, specifically in rural areas, or including rural areas, to explore opportunities to develop or enhance their relationships to increase access. That then led to a 2-year initiative from 2017 to 2019, our Rural Palliative Care Implementation Initiative, which included 5 payer-provider teams that work together, again, to create or expand or improve upon programs in 5 rural areas across the state. And beyond, actually, some of them expanded into additional areas. Finally, just in May 2020, we published Home on the Range, Plans and Providers Team Up to Bring Palliative Care to Rural Californians. And that was a summary describing some of the key learnings from all of these efforts that you'll be hearing about today. And again, before I hand it off to Kathleen, I just want to remind all of you and encourage all of you to use that chat function to offer your perceptions and thoughts and experiences so that we can learn from each other as well as learning from our initiative at CHCF. With that, I will hand it to Kathleen.
Hey, great. Thanks, Kate. I'd like to make a suggestion for a first topic for a chat entry, which is in the course of participating in these CHCF efforts, I got to meet some people who really, really enjoy delivering community-based palliative care or palliative care more generally in rural areas. And if anybody is on the webinar today who feels that way, who just loves this work, loves working in that environment, delivering that type of care to that population, I'd invite you to enter a comment into chat describing why you love it, so we can start off appreciating what's unique and wonderful about delivering palliative care in rural environments. In addition to focusing on what's wonderful about rural palliative care, part of our goal in working on these initiatives and also drafting Home on the Range was to gain a better appreciation of how rural palliative care is different. And one of the learnings that came through in looking at the information that people shared in in-person meetings and reports, in webinars and group discussions, is that rural palliative care really is different. And if you sum it up from the perspective of why it's particularly challenging, you come up with sort of a bit of a daunting compound sentence that I've shared with you here. If you want to offer rural palliative care, you need to go about the business of designing and sustaining a program that will serve relatively few people who have intensive and complex needs, who are spread across huge geographies that tend to lack healthcare services generally, and where there is a shortage of palliative care providers specifically. So wow, that's daunting, not impossible, but that's a big challenge. And that's one of the reasons why it's been so valuable to bring people together, share what they learned about how to do this and make it work, and then also now try to share it with you all. So in developing Home on the Range, and then also the information that we're going to be sharing with you today, we certainly wanted to emphasize those unique challenges to delivering rural palliative care. What is it about doing this in a rural environment that's distinct, unique, and different? But also in reflecting on the information that people shared with us and the things that we observed, we saw that there are also challenges that rural palliative care programs face that any palliative care program would face, whether they were operating in San Diego or Tehama. But these challenges, these common challenges, a subset of them have a particularly intensive impact when they surface in rural areas. The barriers are there, they might be super hard to overcome, and the consequences of not overcoming them can be particularly devastating for a rural palliative care program. So we wanted to call those out. And I should say also that in the information we're going to share today, and what you'll see in Home on the Range, that we did place an emphasis on home-based palliative care services, and in particular those that are supported by contracts with health plans, because that model of payment is so important if you're looking to deliver care using an interdisciplinary team that features team members who can't bill from, for example, fee-for-service Medicare. So as we applied those filters, unique challenges, common challenges that have greater impacts, and also emphasis on home-based services that are supported by plan provider contracts, we were able to distill this down into four categories of barriers and potential solutions: identifying and enrolling patients, staffing services, sustaining services, and attending to the full spectrum of patient needs. We also identified two essential success strategies, which we present in the form of recommendations, which is that you cultivate strong relationships between organizations and individuals, and also that you be creative and flexible with staffing and service models. So let's look at each of these potential barriers and potential solutions and the essential success strategies in turn. So starting out with identifying and enrolling patients, this is certainly one of those issues that many palliative care programs encounter no matter where they are, but the impact of this issue is just so different if you're operating in a rural area. And it's just a simple matter of math. If you're in a fairly densely populated area and you have a contract to deliver palliative care and there's, say, 5,000 potential patients that you might be serving, if you struggle with identifying and enrolling patients, if you only connect with and enroll 5% of those, well, that's still an ample volume to support a small service. If you take that same scenario and put it in a rural area, you might only have 250 potential patients. And if you only identify 5% of those and enroll 5% of those, you just don't have an adequate volume to support a small service. So rural palliative care programs have to outperform their peers that operate in areas with denser populations in order to achieve sustainability. And we were able to identify a few challenges that seem to contribute to this problem, along with some potential solutions to those. Those are the small number of potential patients, the lack of accurate contact information, few resources for a robust patient outreach program, and patient reluctance to accept services. The challenge related to a relatively small number of people who meet eligibility requirements, that's certainly one of those that's related to circumstances where a provider and a plan have entered into a contract to deliver palliative care. And these palliative care programs or benefits, depending upon the payer partner, they can tend to have fairly specific eligibility requirements. For example, the minimum criteria for palliative care offered to Medi-Cal patients, SB 1004 palliative care, it's technically only or minimally only available to individuals with 4 specific diseases who meet very specific requirements related to evidence of advanced disease, and where the patient and family have indicated a willingness to participate in advanced care planning. Those eligibility requirements can be important in that, home-based palliative care is a fairly intensive and expensive service, and you certainly don't want to deliver it to people who don't need it. But the more strict those eligibility requirements are, the smaller the pool of patients who are eligible. And that can be really rough on a rural palliative care program that's looking at a small population of folks that they might serve. And so one potential solution to this is for the plan to really take a look at those requirements and consider adjusting them to increase the pool of potential patients, and also importantly, to make it easier to find them. You don't have to dig through quite so many medical records or talk to as many people in order to say, yeah, okay, this person qualifies for the program. And this practice of relaxing eligibility requirements is not uncommon. In a recent survey that we did of where we had responses from more than 2/3 of the Medi-Cal managed care plans that offer services, palliative care services to Medi-Cal beneficiaries, 81% of them relax the eligibility requirements, either by adding people with different diseases beyond the original 4, expanding access to individuals who have those 4 diseases, but not being so strict about having to see evidence of advanced disease, or by doing both of those things, adding diseases and expanding access. So this is a real viable solution, a viable potential solution for helping with identifying and enrolling more patients. Another challenge that you see is oftentimes or sometimes palliative care providers don't have accurate patient contact information. They might get a nice list from the health plan that says these are the folks who think qualify, but they don't have the right phone number. Well, the solution to this problem that our participants identified most often was just to share data. Health plans can share data with palliative care providers by granting them restricted access to certain areas of their health information systems, or by just designating a contact person who has access to patient files who can share with them the telephone number of the patient. Health systems and primary and specialty providers also have this option open to them. Now, obviously, there's some privacy requirements that you need to be mindful of, but really sharing information here is a great way to hook up people who need extra support with the palliative care services that they're eligible for. Another challenge has to do with the size of the organizations that typically offer palliative care services in rural areas. They tend to be somewhat small, and so they don't have a ton of resources to throw at a super robust and intensive patient outreach program. It doesn't mean they don't do it. Many of them do, but it can be a big hardship. And one way to overcome the challenge of not being able to offer that type of an outreach program is to piggyback on other encounters that your patients might have in other healthcare settings. So, for example, here's a quote shared by a representative from a health plan about how they leveraged contacts across multiple parts of the system in order to identify folks who would be eligible for palliative care. To find patients for our in-home palliative care program, we use our partnerships with our local hospital-based inpatient palliative care units, the hospital palliative care clinic, our behavioral health partner, and our utilization management nurses who are assigned to every hospital and skilled nursing facility in both of our counties, wherever our patients are admitted. So take advantage of the network that's there, take advantage of the other contacts that these patients are likely to be having in other areas of the health system. And finally, you can run into an issue with enrolling patients, even if they've already been identified, if they're just reluctant to accept the service. This is another one of those issues that's likely to surface no matter where you're offering palliative care, but it can be really rough on a rural program if you're trying to build a volume that will sustain your program. And folks identified a couple of potential solutions to this. One is to build on existing trusted relationships with other healthcare providers. So certainly primary care physicians, specialists in the hospital and ambulatory settings, if they already know the patient, having them either orient the patient to your service and say, hey, we're going to have these folks call you. I think they might really be able to help. Or some programs even arrange to do joint visits, for example, to introduce palliative care. You go on by the clinic, and with that primary care provider or that specialist, you have a joint visit with the patient where everybody can hear what's going on, and you can learn about what that patient needs and how you can help them. That can really increase acceptance of services. Another sort of general recommendation as a solution is you just have to be flexible, patient, and persistent. So you need to be willing to discuss and offer palliative care multiple times. It's a good bet that the palliative care provider is new to that patient family. They probably don't know you. It's also a really good bet that they have no idea what palliative care is. And if they hear palliative care, they might assume it means hospice, in which case they might be fearful of it or unwilling to participate in it. And so being willing to talk to folks a few times about what your program does, to hear how you could help them, taking sort of the burden off a decision right in that moment, a one-time shot, can really help. Also, some say that it helps to do the initial outreach, the initial orientation visit in person versus doing it over the phone, so it can be a little more intimate. You can connect more easily with the patient, hear about what they're struggling with, and explain to them how you can help. Unscheduled outreach visits, which were referred to as drive-bys, where, hey, I was in the neighborhood. You're on my list of somebody who might benefit. Can I talk to you about what our program can do for you? Connecting with neighbors, if you have somebody who's been hard to reach, to see if that person's been around. And then also there was strong endorsement of using community health workers, so trained lay people who are trusted members of the community who can serve as that point of first contact to orient a potential patient to these folks actually can help you quite a bit. How about if they come by and talk to you about their service? So that's the summary of the barriers and the potential solutions related to identifying and enrolling patients. Lynn, I wanted to invite you to turn your audio on and share with the group any additional observations you have on this topic or how you've seen it play out differently in other programs that you've had contact with.
Thank you, Kathleen. Can you hear me okay?
Yeah, hear you fine.
Okay, great. I think these are a really complete summary of both the challenges and potential solutions. Two things I would highlight. One is to consider looking at patient need in addition to diagnostic categories, especially if that comes from a referral from a clinician that the patient knows and has a good relationship with, that can be another way to expand both identification and access. And then second, this aligns with the flexibility, patience, and persistent. To start as an opening question when you're establishing a relationship with a new patient and family, from the provider perspective, really asking that important question of, what's on your mind today? What are you most concerned about? What problem is biggest in your daily life that we might, as a palliative care team, help you deal with? Is a way to start out on a very patient-centered approach, and another way to break down some of the barriers that the patient and family might be perceiving. That's all.
Wow. Yeah, no, very helpful. Thank you, Lynn. Hey, Monique, I see that the chat has been quite active.
Yes.
I'm wondering if there's anything from the chat discussion that you want to share with the group who might just be listening.
Yeah, thank you so much. I just want to do a few takeaways from the chat box. First, a tremendous amount of enthusiasm for this work in rural communities, and a few really accented comments about one, really community-based care, that rural palliative care in fact embraces the concept, the structure, and the reality of working interdependently with partners, whether they are the physician and provider partners, but other organizations. Also employing great tools like telehealth to get to those geographically difficult places. And just a mindset that's out of the box, really thinking creatively, as Lynn just said, asking patients right from the outset, what is the biggest challenge or barrier in your daily life? And finally, this concept of building trusting relationships and using the expert team to provide well-rounded, comprehensive, patient-centered services.
Wow. Hey, thank you. That was it's a terrific summary. It sounds like chat is a fun place to be. Okay. Let's go on to the next set of barriers and potential solutions. This has to do with staffing services. And I want to start with describing a syndrome that I observed that many organizations struggle with. It applies if you're a small organization working in a more densely populated area, or for many of the smaller organizations that operate in rural areas. I call it the small organization staffing loop of frustration, or SOSLOF for short. And this is how it goes if you start at the top of the circle and work your way around clockwise. So you're running a small palliative care service. Your organization has relatively few employees. You're not in a densely populated area. You probably have one person who's really the champion for palliative care, and maybe you don't have a very deep bench. And that person provides not only a ton of clinical care, but they also might have a big role in writing policies or doing outreach or interacting with referring providers, just the rock of your service. And then that person leaves. And what can happen relatively quickly then is that all this work that you've done to develop a referral base and a stable service that offers a standardized intervention that delivers quality, you're unable to meet the demand that you spent so much effort developing. And you don't have to have that circumstance go on for too long before you see that your referrals dry up. Providers just won't keep referring you patients if you can't take them on. So you struggle with that for a little while, you recover, you find a new palliative care superstar to join your organization, they come on, and then the process starts all over again, where you invest effort in generating referrals, that gets built up again, and then you find yourself right back at the top of the circle, where you're a small service in an organization with few employees, and you're kind of vulnerable to losing a key staff member. So in terms of the common barriers and potential solutions related to staffing issues, the first two that were identified by our participants certainly contribute to SOSLOF, a shortage of trained providers and difficulty retaining staff, the last challenge, a mismatch between the care model and the available workforce. Well, that creates different problems, but they're equally significant. One challenge in the staffing issue was really related to just the shortage of trained providers. And again, this is something that you'll see no matter where you are in California or the country. It can be hard to find trained folks who can help you out, but it's super acute in rural areas where maybe organizations aren't in a position to compete in terms of salary and benefit packages, or maybe folks are just shy about taking on a role that involves a lot of travel time. It'd be really hard to find folks. And the solution that people endorsed most commonly was just being flexible in your employment model. So think about recruiting and training per diem providers, for example, to supplement salaried staff. That's really effective if you have a uneven or relatively low volume in your palliative care service. You're only bringing on folks for as much time as you actually need them. Another good strategy was to cross-train existing staff from other business lines, for example, home health or hospice, who have shown an interest in palliative care and who are willing to be trained. And of course, we're blessed to live in a time when there's quite a few terrific training opportunities available to folks who want to enter palliative care mid-career, oftentimes online materials. Many are available from CAPC, also some great materials available from the CSU Institute for Palliative Care. Another difficulty that you can encounter with staffing services is just that it's hard to retain your staff. This work can be hard, and it's maybe a little different from the work environment that some folks are accustomed to. And one way to combat this is to really make staff satisfaction a priority. And there's a number of specific steps that folks recommended. One is to just conduct regular team meetings to create a sense of community. You know, doing home-based palliative care in a rural area might be kind of lonely work. You might be by yourself quite often. And so holding regular staff meetings and encouraging staff communications throughout the day using a variety of communication vehicles, that's really recommended. It's also recommended to set aside time very intentionally for team wellness activities. And also, those can be formal, mindfulness or learning about managing stress. It can also just be nice things you do for your staff. There was one program that, just set up in the local high school parking lot, bought a whole bunch of pizzas and let their staff just drive by and grab a pizza and head on their way. You don't need to make it a big deal. It can be pretty easy to do something that just shows how much you appreciate the work that's being done by the people in your organization. Also, offering educational and training programs so people can build their skills. That's often welcome. Providing more generous mileage reimbursements for work-related travel. Home-based care, particularly if you're doing at least a portion of it in person, that can really create a lot of wear and tear, not only on the individual, but also on their car. And being mindful of really what is the cost to them and providing an appropriate reimbursement for that can really help. And also something that is the norm now in the age of COVID, but in case that's ever relaxed, or allowing administrative staff to work from home where it's appropriate and where it doesn't interfere with organizational operations. And finally, another issue that can arise with that can make staffing services difficult. So if you have a mismatch between the care model that you're committed to and the available workforce, you may really, really want to have a team that's nurse social worker led with physician oversight. But if you can't find a palliative care nurse, you can't use that model. And so you need to be a little flexible sometimes and adjust the staffing or care model to match the available workforce. And here's an observation that was offered by one of the palliative care providers that we work with about how they did just that thing. We transitioned from a nurse-led program to a care model that has a nurse practitioner and a physician as the lead staff. This allowed us to open a clinic so patients can see the palliative care physician directly, which is a patient satisfier and helps us respond to symptom management issues. I'd say also this creates another work setting and another potential revenue stream for your providers in case your home-based palliative care volume isn't large enough to support those salaries. You can bill for these services. You can bill Medicare for these services for those providers. So those were the three big categories of barriers and potential solutions related to staffing services. Lynn, do you have anything to add to this?
Yes, I again think that these are right on both challenges and strategies, but I would add in the team meeting setting, the ability to share positive feedback from patients and families, but also to acknowledge the loss as you're caring for patients and families over time. To your point, Kathleen, about the isolation that accompanies this kind of work, team meetings or even a specially set aside time for bereavement is another way to care for one another. And then just the incentive of if you're working with someone in another part of your company that you think would be an excellent addition to the palliative care program, seeking them out and inviting them. That's always feels so good if you're the one being sought out. So to think about that as you're looking to kind of build your bench of others who might be interested in doing this kind of work. So back to you.
Wow. Yeah, thank you. Thank you. Excellent comments, Lynn. Thank you. Monique, anything happening in chat that we should share over the audio?
Let me just put a plug in. We are really enjoying the chat box, and I just encourage anybody who has a thought to go ahead and share that because it's super rich. And just a couple of wonderful takeaways, and I really appreciated your comment, Lynn, about recognizing and acknowledging some of the grief too that comes with this work. In the chat box, our colleagues were talking about the value of being super creative, kind of scrappy, being flexible. They also talked about setting goals with staffing and employment in general. Even if you don't make those benchmarks, it's just a North Star. There was a comment about honoring and supporting staff with both that positive feedback that just gives everybody the dose of serotonin we all need. And finally, another comment is getting administrative buy-in, making sure that the employment and the staffing goals are shared broadly and endorsed and supported with that education and training and the cross-training.
Wow, thank you. Great.
And Kathleen,
go ahead.
Yeah. Well, there was a raised hand, which I see just went down. So I'm not, I'm not sure whether Julia Castle-Godley had a question, but I did see your raised hand. And so I think I'm going to briefly unmute your line. And if you have a question, please go ahead, or a comment, please go ahead and ask it. And if you don't, we will just remute after a moment. But I'm going to unmute you in a moment. All right, I believe Julia Castle-Godley, you should be unmuted. Oops, except, let's see. Okay, I think you might need to unmute yourself if you had a question. It seems to not be working on my end. Sorry about that. Julia, if you did have a question you were trying to ask and you can't unmute yourself, go ahead and type that into the chat and we'll try to get to it through the chat box.
Okay, great. Yeah, I'll keep an eye for that. All right, next category of barriers and potential solutions has to do with sustaining services. And again, something that every palliative care program, no matter what the setting, has to wrestle with. And when you think about sustaining the service, it's really about achieving balance. You have scope of effort, scope of your services, which tracks to how much effort you put into caring for each individual patient. That needs to be balanced with the amount of payment that you're receiving. And the amount of payment that you're receiving needs to be balanced with the outcomes that, that justify the investment in the service. And you can see how this can easily get out of balance. If you have just a super comprehensive scope of services, if you're providing essentially hospice plus for every patient who's referred to you, that takes a lot of effort, but it also takes a lot to get that paid for. And if you are being paid to cover all of that effort, it might be that the outcomes that you deliver, because maybe your service is a little too hot, you're providing a little too much support to people, your outcomes may not justify the investment. On the other hand, if you're providing that super duper comprehensive hospice plus level of care, but you're only getting paid at, say, the Medicare Care Choices model level, you're getting about $400 a month, you're not going to be able to sustain that. And so you're out of balance in that way. So you need to have these three categories, these three sets of variables level in order to have a sustainable program that works for you and that works for the entity that's providing payment for your services. And there can be some particular challenges around sustaining programs, many of which are linked to this issue of creating balance. So one is uncertainty that revenues will cover your costs in the setting of low or uneven volumes, the high cost of care delivery in rural areas, the fact that sometimes plans and providers have very different expectations and knowledge of what true cost of care delivery is. And also you can have coverage misalignment. And in particular, if the types of patients who need your service don't have the type of insurance coverage that allows you to get paid to deliver care. So let's spend a little time looking at this. So the first challenge, uncertainty that revenues will cover costs. So, you can wind up in a situation where your volume is uneven, or you're taking care of quite a few folks who maybe don't have, where you're not getting compensated for care delivery. That can really throw your service out of balance and threaten your sustainability. So potential solutions to that is, one, is you might have a little broader and more holistic look at what your palliative care service is doing for the larger organization if you offer other lines of business. So for example, home health or hospice, it may be that you're generating more revenues in those services because of your connections with palliative care. And you might consider the overall sustainability, the overall profitability of your organization, looking at palliative care as something that maybe just has to mostly support itself in terms of direct costs and allow your other more profitable and perhaps more stable service lines to do the work of taking on your indirect costs of care. Another strategy that can work to offset this barrier is to share staffing costs, either within the organization or across business lines, or with your plan partners. So sharing costs across business lines could be that, maybe borrow social work or borrow chaplaincy staff from your hospice program. So you're sharing the cost of those individuals with another business line. Or in some cases, plan partners might be willing to help to pay for the cost of a person on your team, in particular if you're offering a distance-based service and you need to have somebody locally to help facilitate care delivery. And that's exactly the circumstance that one of our provider partners, one of the palliative care providers, was able to arrange for, as described in this quote. Our team is comprised of a physician, 2 nurses, a care coordinator, 2 community health workers, a social worker, and a chaplain. The nurses and the CHW see patients in person in addition to video conferencing, while the rest of the team provides care via telemedicine and telephone. The community health workers are employed by the plan and support our care team on an as-needed basis. They are available to go to patient homes to check on them, in particular if our team is having difficulty contacting the patient, and to facilitate video conferences for members of our team. So it is not common, but the only time I've seen this is in rural areas where a plan might be willing to help you to support the program by covering some staffing costs, in particular in the beginning when you're in a ramp-up phase and you don't have quite enough volume to support your service. Another big issue related to sustaining services, and this is somewhat particular to rural areas, is the high cost of care delivery. Delivering care in rural areas, in particular, if you are not mostly or fully delivering telehealth or telemedicine services, it just costs more. It takes a long time to reach patients. Patients can have multiple complex issues, and maybe there's not as many resources around to help them take care of it. And a big way to help to offset this issue of high cost of care delivery is for the palliative care provider organizations to really think about what they can do to focus on efficiency, what can be done to reduce the cost of care delivery. And there's a few strategies here. One is to focus on per diem staff, and we've talked about this before. So you can't really afford to take on a full another half or full FTE of physician or nurse practitioner or nurse. Well, maybe you can arrange to only contract for those, especially the relatively more expensive services, on an as-needed basis. Also, using telehealth is something that we all became really accustomed to during the COVID pandemic, but it is really an incredible tool for increasing the efficiency of your service, for reducing the cost of care delivery. And finally, also think about incorporating lower cost disciplines into your standard service model. So perhaps using community health workers as a supplement to the services that are delivered by your social worker, using LVNs to supplement care that's delivered by registered nurses. Another challenge is that sometimes plans and providers have very different expectations and knowledge of care delivery costs. Now, if you're working with a Medi-Cal managed care plan, they operate in a rural area, they know it well, they probably understand just how expensive it can be to deliver rural-based services. But if you're partnering with somebody who maybe is operating, across the entire state, or and rural areas is just one place where they're looking to deliver, say, a plan-wide or an organization-wide palliative care benefit, they might not be quite as familiar with what it actually costs to deliver care in a rural environment. And here, the recommendation is simple but very effective. It's to collect data about what you do and how long it takes you to do it, the specific needs of your patients and the specific services that you're delivering to them, and then to communicate early and often with your plan partner, with your payer partner, about what your real costs of care are, and then to create that alignment between this is the scope of services they want you to deliver, this is what it costs you to deliver them, and how can you get that payment aligned so that nobody feels like they're paying too much or receiving too little. And I've included here for you the only study that I know of that's done a published study that features a time motion study of delivering community-based palliative care. It's done by the folks out at Duke in collaboration with the folks at Four Seasons Hospice. I don't know that you would want to use the findings in this paper as a benchmark, but it certainly is an example of the different categories of effort delivered by different disciplines, creating a framework that you could replicate locally, even on a short-term basis for a couple of weeks. This is how long, everybody, let's keep track of the work we do and how long it takes us to do it. Another issue that you can run into in sustaining services has to do with your relationship with the community and what the payer mix is in your community. And what is very common to find is that the majority of individuals who need palliative care, home-based palliative care in particular, they may have fee-for-service Medicare as their primary payer. And if you are looking to use an interdisciplinary team, perhaps led by a nurse, social worker, chaplain, with support from a physician or a nurse practitioner, but they're the ones who are doing the bulk of care, you can't cover those costs. You can't bill for their services to fee-for-service Medicare. So what do you do if that model is dominant? Well, what some folks have done is actually to consider using a provider-led model. So you use a model where the physician or the nurse practitioner is the primary person who's delivering care because they're the ones who can actually bill Medicare if they're the dominant payer in your environment. You can also, run this provider-led model concurrently with a nurse-led or a social work-led model. It can create some operational challenges if you have two different practices, depending upon what type of insurance coverage the patient has. Here, the low volume might work in your favor, where you don't have to keep track of too many folks in order to route people to the intervention that matches the services that they're eligible for based on what their payer pays for. So that's it for sustaining services, the four top issues and potential solutions that we identified. Lynn, your comments and observations in this area.
I think over time we've learned that a lot of the needs of the seriously ill patient population that we're working with are social needs. And to your point, Kathleen, about expanding the role of community health workers, I think that can often help with that balance goal that we're trying to achieve with sustainability as the important goal. And then second, I would just add that metrics, measurement, feedback from patients and families, in addition to some of the data from the health plan, are really foundational to long-range sustainability of your services. Back to you.
Wow. Yeah, great point. Thank you, Lynn. Hey, Monique, anything going on in chat that you want to share?
Yeah, there was one comment that about a major challenge, of course, and it's related to sustaining services, is how to maintain contact with some community patients, those who may be moving around, and it's difficult. So just setting up that challenge. One of the things I wanted to harken back to is in the Rural Palliative Care Project, what we saw over and over again with respect to sustaining services was that flexibility and resilience to go back to everything from looking anew at communication patterns with plans and providers, but also something that was maybe a little bit sort of grittier, which is being okay with trying new things and maybe failing, or having to start again to look at some of these opportunities that you outlined in this section of whether it's using CHWs a little bit more creatively, but sort of looking at the broad and long-term perspective of sustainability is an ongoing process. And so if something doesn't work, trying again and being heartened by that you are committed to your community.
Yeah. Thanks, Monique. All right, the final category of barriers and potential solutions. Attending to the full spectrum of patient needs. The goal, everybody's goal, whether you're a provider or a plan or a primary care physician or a specialist, everybody wants to deliver quality, comprehensive, accessible care. But that can be super tough to do, especially in rural areas, partially because you need some things to make that happen, but those things aren't always there. And in particular, timely access to primary and specialty providers. They may be in short supply and they may be some distance away. Supportive services like case managers, and also there's many areas in rural communities where there is not a hospice that's close by, and certainly you would want that to be available to provide quality, comprehensive care to folks who have serious illness and who are approaching the end of life. There's also some complicating factors related to rural environments. They're not universal, but they're common. There can be a high prevalence of substance use disorders, and that can certainly complicate the delivery of palliative care. There can be poverty, and that certainly complicates the delivery of palliative care. And also, you tend to have an older and isolated population, and all of these things can make attending to the full spectrum of patient needs more difficult and more important in a rural environment. And the particular challenges, the particular barriers that people identified were you can have folks who have complex needs, and there can be not quite enough resources around to attend to those. There can be underutilization of the resources that are available. It can be difficult to engage with primary care providers who may be super busy and overburdened or just not knowledgeable about palliative care. And finally, this issue of what to do when there's no local hospice. In terms of attending to the full spectrum of patient needs, there can be complex, these patients tend to have complex needs, and there can be not a lot of resources around to help them with them. And the recommendation of the folks who we worked with was to really adopt care processes and staffing models that are as broad as possible, that are as inclusive as possible. So for example, you can use trained community health workers to initiate advanced care planning discussions and provide links to community resources. You can also really partner with your plan, which might have multiple programs, and they might have a deep understanding of what this individual needs. You can conduct regular meetings, sort of cross-organizational IDTs, to review the enrolled patients, to resolve any challenges that you're seeing related to meeting their needs, and to ensure referrals to appropriate services, some of which may be offered by the health plan. Also, you might run into an issue where there's services and supports available, but patients just may not be using those. And the palliative care team can play an important role in orienting individuals to what's available to them, and then encouraging them to take advantage of those supports. Things like housing supports and transportation and meals. And again, some of those supports may be available from the plan itself. Also, there can be difficulty engaging with primary and specialty providers. These folks can be super overburdened. They can be some distance away. They also may not understand what palliative care is. They also may be suspicious of palliative care if they have any feeling that it's going to make their lives more difficult. And this is something I was really surprised to learn about. But if, for example, you have a nurse social work-led model and you're making recommendations about pain medications, and no one on your team can make that prescription or manage that medication, the primary care provider might see this as one more thing they have to do that maybe they just don't feel like they have the bandwidth to tackle. So one way to address this barrier is to have the palliative care team assume some of those primary care responsibilities if it would be helpful. So, for example, the palliative care physician could make direct referrals to specialists or services rather than waiting for a primary care doc to act on a recommendation. And this is something that is often asked for in relation to medications, and something that you should consider if it's appropriate for your service to do, to have your own team physician manage and prescribe medications to support palliative care, primary care providers. And finally, this issue of no local hospice exists. Within 50 miles, you have a patient who's seriously ill, who's approaching the end of life, who's hospice eligible, but there's no place to send them. Your team, in fact, has the deepest concentration of palliative care expertise, of end-of-life care expertise, and they're the ones who are best suited to take care of this person. Well, this is certainly something that your organization could take on. You could meet the need, but you really need to make sure you adjust the contract. Again, in service to that concept of keeping balance across your effort and your cost of care delivery and your payment. And so this was actually achieved by one of the provider groups that we worked with. As they described, our contract is based on a per member per month payment structure, including 3 tiers of service. The most intensive tier, called virtual hospice, is used if the patient has no access to on-the-ground hospice services or is unwilling to enroll in hospice care. So they deliver the service, but you know what? They also get paid appropriately to do so. So that's it, according to for the 4 major categories of barriers and solutions related to attending to the full spectrum of patient needs. Lynn, what more do you have to offer on this topic?
I think as you talked about the different levels of service that a program might develop, as well as engaging with primary and specialty providers, it just reminds me of the importance of communication, which fortunately is a strong part of the skill set of palliative care teams. But to keep all those lines of communication open is really, really critical to the success of meeting patient needs.
Yeah, thank you. Monique, anything to share from chat?
Yeah, so we had a couple of comments, and one is just reflected in the slide about an organization providing virtual hospice for those living in areas without hospice services, and also doing this really creative outreach with volunteer hospice providers in some of those more remote areas. At the same time, another comment which balances that is really recognizing meeting the full spectrum of patient needs and attending to them is difficult. It's difficult to identify and train caregivers and provide comfort kits, and really having a team that's willing to do that. So those are some of the challenges that remain for this area.
Yeah. Wow. Thank you, Monique. All right. Well, let's talk about these broad categories of recommendations that we had, what we call essential success strategies. The first of which is to cultivate strong relationships between organizations and individuals. And this has certainly come up when we've spoken about barriers and potential solutions. But in a rural area in particular, where there probably is a lot of knowledge about individuals and a lot of reliance across organizations, it's really important to build relationships with hospitals and health systems, medical groups, social service organizations, the local health departments, emergency medical technicians, and you build these relationships to help with identifying potential patients, educating providers about palliative care generally, and your program specifically. You should not assume that any individual actually knows what palliative care is, even if they have a credential after their name. Expect to have to explain it, and then expect to have to explain what palliative care means from your organization, since there's still tremendous variation in how palliative care services are staffed, patients they take care of, the services that they provide. Similarly, these relationships can really help you in educating patients about palliative care generally and referring to your program specifically. Just as a lot of providers have no idea what palliative care is, the overwhelming majority of patients and families will not know what it is, but when it's described to them, they'll say, oh yeah, that sounds okay to me. And again, you'll want to make sure that they understand what your program can do specifically for them, and these relationships with other organizations can really help you in doing that if they're hearing the information from an individual or an organization that they already trust. These cross-organizational relationships can also help with promoting appropriate referrals. So not just identifying the patients who might need care, but actually referring them to your service. And also can help to make sure that individuals are appropriately accessing community resources. And this is super important to keep the burden of your palliative care team manageable. If there are other entities in your area, you can take on part of the burden of meeting those complex needs that we talked about that can really help you to maintain sustainability for your program. And finally, in terms of an essential success strategy, we recommend, the folks who we worked with recommend that you be creative and flexible with staffing and service models. And we've touched on a lot of this already in terms of barriers, but one, include community health workers on the palliative care team. It can be a very effective and cost-effective way of delivering core services and also for building trust in the community. These individuals can serve as a bridge between the community and your palliative care program. Really pay attention to standardizing your processes to maximize quality and efficiency, having criteria for initial response time, having a standardized approach to doing that comprehensive assessment that can really make sure that you're delivering a predictable intervention that's delivering the outcomes and services that your partners expect, whether those partners be referring providers or a health plan that's paying for your services. Also, plan for inevitable personnel changes. You know, we talked about what can happen if you lose a key staff member. Instead of just hoping that it won't happen to you, plan for it. As Lynn described before, build your bench before you need it. Identify individuals who might be interested in delivering palliative care. You can help to train before you even need to include them in a big way on your service. Cross-train individuals within your organization. Try to share the load across folks so that you're well positioned to weather the storm if you lose somebody who's central to your organization and to your palliative care program. And finally, again and again and again, embrace telemedicine and video visits. When you're offering care across a vast geography, cutting down on those hours and hours of windshield time can really help you to make the most efficient and effective use of your scarce resource of palliative care providers. And it's worth remembering, and perhaps this is something that you all have had experience with in the time when COVID has spread, is that not every provider is going to be comfortable in delivering care via the phone or via a video visit. And also it tends to not be all or nothing, at least in a time when we're allowed into our patient homes. So typically it's a hybrid approach. You might do the first visit in person and then transition to telemedicine. You might do the first visit in person by the physician or you might have in-person visits by the nurse and the community health workers, but the physicians and the nurse practitioners always engage with the patients via video. You'll need to do some experimentation, see what's the best way to deliver that care. Finally, I want to share a couple of resources. One, as Kate mentioned, Home on the Range, the write-up of our lessons from a variety of rural palliative care program development projects that's available on the California Healthcare Foundation. Just enter that title into your favorite browser. Also, the folks at Straightest Health, an organization that Lynn's been involved with, they've done a bunch of initiatives related to community-based palliative care. They've curated their tools in this resource center, and there's some nice things that you can access by using that menu on the left-hand side, worksheets and such that can walk you through the process of understanding what palliative care is and what your patients need, planning, and so on. Also, Straightest put out a lovely write-up addressing sustainability strategies for community-based palliative care. It's brief and to the point and super useful, a nice blueprint for those of you who are trying to figure out how to make your program sustainable and viable over time. And then finally, there's another set of curated information. It's put up by the Rural Health Information Hub. They have an entire section addressing rural hospice and rural palliative care. Again, if you go to that left-hand menu, they have some interesting resources there, as well as some write-ups of models and innovations that you might find useful. And with that, I'd like to just say thank you to you. Thanks for attending today. Thanks also, a special thanks to the health plans and the provider organizations that participated in the Increasing Access to Rural Palliative Care in California project. I saw that some of you are on the phone today. Hello, thank you for joining. Thank you for sharing your comments in chat. Thank you for the work that you've done to improve care for seriously ill Californians and for sharing your wisdom and your experiences, and just call them out by name here. And so with that, I want to hand it back over to Kate to wrap us up.
Well, thank you so much, Kathleen. And I want to echo these thanks to our partners in this Rural Palliative Care Initiative that we conducted over a couple of years. And we learned a lot, and I know we all still have more to learn. So look forward to continuing to keep in touch with this network of people interested and invested in rural palliative care. Thanks also to Kathleen and Monique and Lynn for their leadership on the initiative and on this webinar. And thanks to all for attending and for your active participation in chat. The recording and slides again for this webinar will be available on the CHCF website under our events page within, I'd say a week, could be sooner, but it's a week to be safe. And thanks again for your time today. Have a good one. Take care.
Bye, everybody.
Bye-bye.